Hey guys, welcome to our lesson on neonatology. We last left off our conversation in regards to birth with our obstetrics and gynecology lecture. We're going to take obstetrics a little bit further beyond the birthing phase and into the component of dealing with a newborn or a neonate. I do want to start us off by reviewing a case study from your textbook that's going to be found in Chapter 3, page 54. The case study goes like this. It says, a storm rages outside, making travel dangerous. Around midnight, you receive a call from the dispatcher. A woman has just gone into labor. She lives about 20 minutes from the hospital, but her husband is worried about the weather conditions and requests help from your EMS unit. On arrival, you find a 24-year-old woman who is about to deliver her second baby. You quickly determine that there's not enough time to transport the patient to the hospital, and you and your partner begin to prepare the equipment necessary for a field delivery. The delivery itself goes beautifully, and you announce the arrival of the couple's new daughter. Following the birth, however, the baby remains blue and limp, even after you quickly dry the baby and wrap her to keep her warm in a blanket. You stimulate the baby, rubbing her back and flipping the soles of her feet gently. When the baby stays blue and limp, you push aside a very normal urge to panic and deliver breaths using a bag valve mask unit on room air. The baby begins to pink up almost immediately and then begins to cry. Using the pulse oximeter, you determine that the oxygen saturation is 95% and increasing. You prepare to transport the baby, making sure the head is covered. You ask the mother to hold her new daughter and then load both your patients into the ambulance for safe transport. En route to the hospital, you continue to monitor the infant and assign a 5-minute APGAR score of 9. The trip is uneventful. The baby leaves the hospital only one day after the mother. The parents later pay a surprise visit to you and your EMS unit to proudly introduce their healthy baby daughter. The reason why I wanted to share that case study with you is because oftentimes when we think about birth and the delivery of a newborn, most often things will go normal. But there is an instinctive response that you will have to panic when things go awry. Even though they're in a small amount of occasions, you can still easily get into an emotional turmoil and lose your ability to concentrate and focus on your patient. So I want you to keep that case study in the back of your mind as we progress through this lesson, because when things go awry, we have to recognize that EMS is the calm to the storm. And when we arrive, the emergency is over. The professionals are here to take care of that newly born child. Regardless of the emotional turmoil we have, we must remain like a duck. As strange as that sounds. You think about a duck floating on water, they glide across the top effortlessly, beautifully smooth across the glassy water surface. But below the surface, their feet are paddling like crazy. That's the internal rush you're going to have, and with neonatology, we must recognize that and do what we can to blunt that sympathetic response we have. Let's go ahead and get started on our lesson. Three primary topics that we're going to discuss. The first is the general pathophysiology assessment and management of a neonate. We're also going to talk about the distressed newborn and then the specific neonatal situations you may get into and the resuscitative care that needs to be implemented. When we think about what is a neonate, we often hear the term neonate and newborn used interchangeably. And that's okay, but they both have a specific outline for definition. A neonate is considered an infant from the time of birth to 1 month of age. So from birth to 1 month, we call them a neonate. A newborn is a baby that's recently born and is in the first few hours of their life. Again, they're known as a newly born infant. An infant itself is going to go from 1 month to 1 year. Let's take a look now at some general pathophysiology assessment and management techniques that we apply when dealing with a neonate. First thing we have to recognize is that approximately about 6% of field deliveries require life support. That lets us know that 94% of field deliveries do not require field support. So it's not many. Just like we see with anything, when we have less likelihood of responding to it, we know that we need to train more to be more efficient at dealing with those cases that don't happen very often. We also know that there's an incidence of complications that increase as birth weight decreases. So as a newly born neonate, if the child is very small in weight and stature, we know that they're oftentimes going to have more complications compared to that of a child that's larger. Although larger children could have more birth-related complications or birthing process complications, the smaller the child, typically the more concern we have. Approximately 80% of newborns are going to weigh about 3 pounds, 5 ounces. Those folks that are weighing about 1,500 grams are going to typically require some type of birth resuscitation to help their body transition from mom and their environment in uterine to extra-uterine life outside in the real world. Now, there are some antepartum and intrapartum factors that we must consider. We have to determine at-risk newborns by considering factors that may indicate delivery complications. So even before we deal with our neonate, before they actually arrive, we want to anticipate complications that can occur that are happening through the host or through mom. Antepartum obviously are the concerns that happen before the onset of labor. These could be things like prolapsed cord or early rupture of their water or membrane breaking. And then we have intrapartum, which occur during childbirth. These could be problems like shoulder dystocia or a breech delivery, any of those types of components. A nearby neonatal intensive care unit or a NICU makes the best choice for these kids because we know they are at risk because generally they're going to have more complications because of smaller birth weight. Not that that always happens, but again, we want to consider it. If we look at some risk factors indicating possible complications in newborns, we can take a look at the antepartum versus the intrapartum. Antepartum, again, we talked about multiple gestations. We have more than one child. The more children we have, harder it is to keep them warm because they're smaller. Again, they can only grow so big because there's more than one of them inside the uterus. Inadequate prenatal care. Obviously, if mom's not taking the appropriate prenatal vitamins or seeking medical attention regularly to monitor the progression of her pregnancy, things can become awry. Mother's age, less than 16 or over 35, typically have more concerning problems. History of prenatal morbidity or mortality. And then post-term gestation, drugs or medications, toxemia, hypertension, and diabetes are all common things we would see as antepartum factors. Antepartum factors, these are things like preterm labor, meconium-stained amniotic fluid, ruptures of the membranes earlier than 24 hours before delivery, that's breaking of the water, the use of narcotics within 4 hours of delivery, abnormal presentations, that's again a breech or limb presentations, prolonged labor or precipitous labor or rapid onset of labor, and then prolapsed cord or any bleeding that can occur as well. So we have to recognize these risk factors as they occur because we can anticipate the need for neonatal resuscitation because now we can have potentially 2 patients or more that may both be critical and need extensive amounts of pre-hospital care. Now let's switch gears here to pathophysiology a little bit. To prepare for extrauterine life, the respiratory system must suddenly initiate and maintain respirations. Remember that the neonate, or the fetus, we should refer to them as, is dependent upon mom's oxygen supply. So as mom is breathing in and getting adequate supplies of oxygen, that's transferred directly through the umbilical cord, through the placenta, umbilical cord, and then into the fetus as it grows and develops. Once the child has completed the birthing process and is now exposed to atmospheric air, there is a number of physiological changes that will occur to close off the circulatory system that was in operation for mom, providing the oxygen and providing the blood flow, and now into them being dependent on their own components. There's a number of different types of closures that we see within the circulatory system. We'll talk about more about those and ligamentum teres and ligamentum arteriosum, where these ligaments are actually where the pregnancy circulation was coming into the child, and as they breathe and are stimulated to breathe air in and to fill their lungs up for the first time, we typically will see that those ducts will close. We'll come back to that. A third of fetal lung fluid, that's what the slide should say, is removed through compression of the chest during vaginal delivery. As the child progresses down the birth canal, as the birth canal squeezes during contractions, as it begins to push it out, we know that that's actually a major important portion of expelling any of that amniotic fluid that generally would fill in their lung. Again, a third of that at least. There are some factors that we can do to help stimulate respiration. Remember, when you walk into a house and it's quiet and a newborn has been delivered, that should concern you. When you walk in and hear a screaming child, you should be able to take a breath of relief because you know that that child has an airway and is breathing effectively. Remember, the number one reason why children or pediatrics or neonates will go into cardiac arrest is hypoxia due to some type of airway complications. These are very easy, especially when they're so small and new to the world. Factors that can help stimulate respiration, mild acidosis, indication of stress reflexes in the lungs. Again, that's going to happen as they are going through and they're getting compressed as they're pushed through the birth canal. Some hypoxia and some hypothermia. So obviously those are going to be some of the things that we see regularly as part of a normal delivery. We want to try to do as much as we can to support the child and support those components to help stimulate respiration. Here's how some of these things are actually going to take a look as far as what they do internally. I'm going to grab my laser pointer here. So we start off here with the initial expansion of the lungs. We have the initiation of respiration. We know that child comes out. We're going to go ahead and stimulate, warm, flick the soles of the feet, stimulate the child until they begin to breathe. As they begin to breathe and they actually start to utilize their own pulmonary system, we're going to see increased levels of PO2, the percentage of oxygen within the blood. Now this has a lot of things that happen. We're going to go ahead and follow this up through the top here first. Increased PO2 levels cause a decreased pulmonary vascular resistance. So there's less resistance in the lungs. That leads to an increase in pulmonary blood flow, now that the blood can flow to the lungs easily without that systemic vascular resistance, or pulmonary vascular resistance, I should say. From there, we see that the left atrium begins to pressurize, and as that left atrium begins to pressurize, we start to see the closure of the foramen ovule, and that is going to be where the deoxygenated blood will be poured in from, or oxygenated blood will be poured in from mom, and then travel through the rest of the system, skipping the pulmonary system. We also know, if we go to the other end here, which also helps the closure of the foramen ovule, is we see increase in systemic vascular resistance. We also then see a decrease in systemic vascular return or venous return. And then we also see a decreased right atrial pressure. Both of those things are going to help close that foramen ovule. Now, as we start to see a decrease in systemic return, we're going to see the stopping of the umbilical venous return. Right? So no longer, blood is now getting in, that's the closure of the foramen ovule into the right atrium, that will close off. And as systemic vascular resistance increases, as again the child's using its full circulatory system on their own, we start to see the lack of blood flow to the umbilical cord and the closure of that ductus venosus. And that's going to be, again, one of the primary locations where the blood would typically go from the umbilical cord back to mom. Now, as we see the increase in systemic vascular resistance, there's another pathway that it takes, and that is as systemic resistance becomes greater than pulmonary resistance, we see the closure of the ductus arteriosus. That's where we start to see what would be considered a left to right shunt based on pulmonary resistance, which again is less than systemic resistance. So all these physiological changes are happening based on the fact that the child breathes. And so in order for us to ensure that the child remains healthy at our 1 and 5 minute APGAR scores, we need to make sure that they have adequate PO2 levels, which means we need to help them breathe if they need it. We need to stimulate them to breathe and cry on their own, and do as much as they can to increase oxygen, to increase the resistance or decrease the resistance to the lungs, increase systemic vascular resistance, and close those different ducts, the foramen ovule, the ductus venosus, and the ductus arteriosus. Here's another way of kind of taking a look at this from another image here that we have. If you take a look at this, you can see here is your placenta, here's your umbilical cord, right? And here's where the umbilicus actually enters into the fetus. The umbilical artery is going to go ahead and travel on down here through to the iliac arteries, right? It's really not doing a whole lot of components, but it is dumping, again, any type of overflow or deoxygenated blood in that location. The umbilical vein, which is actually carrying oxygenated blood, it's treated like that of an artery, is going to travel up and it's going to go ahead and hit right here into the liver. Right here at the liver, as we start to see your vena cava, the inferior vena cava, and which is in the posterior side, and then you have your umbilical vein coming up, is the ductus venosus. This is going to be one of those areas that's going to start to close off as we start to increase systemic vascular resistance and increase oxygenation. That's going to prevent the backflow of blood going to mom. The other one that we're going to be dealing with is up here in the right atrium. That's that foramen ovule, and that actually allows for the bypassing of the lungs. So in essence, blood is allowed to go in through the right atrium, down into the right ventricle, and then it just keeps circulating in these areas here rather than necessarily going up to the lungs, because it's not necessary completely for that. Now, even though some blood will circulate, some blood will travel up through the pulmonary artery, and when it does that, there's what's called the ductus arteriosus. And that ductus arteriosus is where it's going to be mixing of artery blood and venous blood. And you can see that as your aortic arch were to come down here, you would normally see oxygenated blood traveling down here. You're actually going to get a mix of blood that's happening this way. As the child begins to breathe, we see a closure of the ductus venosus, which is going to allow for no longer for blood supply to travel in from mom. We see the closure of the foramen ovule, which is going to allow for the pulmonary system to work independently. And then we're going to go ahead and close the ductus arteriosus here, which is going to allow for the lungs to have a direct impact on oxygenation rather than it happening or coming from the umbilical vein from mom. So hopefully that makes a little bit more sense as we kind of look into that. Again, just another way of looking at it here. Again, ductus venosus, ductus foramen ovule, and then the ductus arteriosus. So the ductus arteriosus after closure becomes the ligamentum arteriosum. These always remind me of Harry Potter spells. But it does become the ligamentum arteriosum, which is going to support those major components of arteries, like your aortic arch. If hypoxic or severe acidosis occurs, it can actually reopen, which is going to cause that mixing of both venous and arterial blood, and that's not something we want to see happen to our patients. Again, it's going to result in persistent fetal circulation. We want them to be on their own circulation, not necessarily dependent on them as they were once they were a fetus. We want them on their own neonatal circulation. Again, we talked about that mixing of both arterial and venous blood, and it's going to send higher pressures to the vessels through the lungs. Again, that's going to make it harder for the lungs to be able to function as they need to. It is important for the paramedic to recognize that the first few breaths after life, or after birth, are extremely important to maintaining the vitality of that neonate. We need to help close the ductus arteriosum. We need to make sure it remains closed in order to have adequate circulation. And again, the goal is focused on prevent hypoxia, prevent acidosis. Now, if we look at infants that are susceptible to hypoxia or hypoxemia, primary apnea is one of the big concerns we have. They're delivered, but they don't want to breathe on their own. Primary apnea is also referred to as initial apnea. These are typical cases where we have a patient who's hypoxic, maybe they're bradycardic, or they have no effective use of respiratory muscles. Generally, simple stimulation and oxygen delivery will reverse the bradycardia. Now, that's the goal, right? We go ahead and we begin to ventilate them with the bag valve mask on room air or oxygen if we have the capabilities, and see if that makes a difference in assisting them to close off that ductus arteriosum and some of the other ducts that we've been referring to. If that remains in effect or continues, we refer to that as secondary apnea or prolonged apnea. This is where we start to see some major downturns in the neonate. Things like agonal respirations, vital signs that begin to drop off, oxygen saturations that begin to drop off. The infant becomes unresponsive to stimulation and will no longer spontaneously resume regular respiration on their own. In that case, ventilation, oxygenation, and even chest compressions may be necessary to help support the neonate as they continue to need additional resuscitation. Now, one of the things that we have to recognize when we're dealing with a distressed neonate is that about 2% of deliveries will have some type of congenital problem. Typically, it has a problem to do with fetal development. Mostly, it's concerns with the heart. Either there's additional openings in the heart, inappropriate development of the heart, or any number of those different components, and we'll talk about those in detail here. But several recognized patterns are called syndromes, and they may occur. And these syndromes are where we have congenital abnormalities that may make resuscitation for the neonate even more difficult, if not impossible. And again, congenital heart defects are among the most common of that 2% population that we deal with. So what are congenital heart abnormalities? Well, classifications happen based on the different locations. First is things of increase in pulmonary blood flow. This is where we have a patent ductus arterius, but we have things like a septal deficit. And we're seeing things like potentially like a mixing of oxygenated blood, or it could be a ventricular septal deficit. When you look here, one of the big things when we see first off is the patent ductus arteriosum, where it's not actually closing yet. And so because of that, we're going to continuously get the mixing of oxygen and deoxygenated blood, which is going to mean that the lungs are going to have a more difficult time oxygenating blood, and potentially we may see deoxygenated blood being pushed throughout the remainder of the arteries because of that open duct. As you can see here, you can easily see that that duct is going to be causing a mix of oxygenated blood and deoxygenated blood within the pulmonary artery. The next one we look at are going to be septal deficits. These can be atrial and ventricular. Here's an example of a ventricular septal deficit here. In this case, you can see blood is going to get mixed here between the right and left ventricle. The right ventricle is going to get mixed oxygen through the pulmonary artery, which should be deoxygenated blood. And we're also going to see that we're going to not have adequate output from the left ventricle up and through the aorta to the aortic arch because of that ventricular opening. If you look at a atrial version, again, it's very similar, but you can see that we're going to get a lot of extra work in here as oxygenated blood dumps into the right atrium, pumped to the right ventricle, and then goes on up into the lungs. Again, most of that is going to be partially oxygenated as well, and causes a number of different abnormalities, or at least issues with getting the patient back on their own, sustaining them where they're pink, they're crying vigorously, doing well. Other ones that we can look at can be things like decrease in pulmonary blood flow because of the trology of follow-up. That's another one we typically would see here. There's 4 congenital abnormalities that can occur with that, and with where we also can see things like transposition of great vessels, or dextrocardia, where the heart is backwards, where the right is where the left is and the left is where the right is. Any of these can lead to a lot of complications with the ability for the patient to have their own circulation with a neonate. So we have to recognize these, and we have to recognize the difficulties that we may be up against when there are congenital abnormalities. Even though they're rare, they do occur. Here's an example of another one of an obstructive blood flow. This is where you can have contractions of the aorta or a narrowing of the aorta. This one is going to be an example of a pulmonary aortic or mitral valve stenosis, where it's a very narrow opening, causes a back of resistance. The valve itself starts to become an obstruction. We also have hypoplastic left heart syndrome, where they just don't have an adequately developed heart, specifically left ventricle. Usually that's going to be fatal within 1 month if they don't do something to correct that, to give the left ventricle the power it needs to go ahead and push that blood to the remainder of the body. Again, a lot of different things that we're going to look at with congenital heart abnormalities, all of which are concerns. We want to see things like we have pulmonic stenosis, where the pulmonary valve itself is narrowed. We have aortic stenosis, where the aortic valve is narrowed. We can also have co-arcing aortas, where we're actually seeing a decrease in blood flow because the aortas and the right atriums are actually connected together. All of these are going to be common problems that could be leading to the reason why our patient isn't improving after the use of oxygenation during that primary apnea, or it may be the reason why they continue into a secondary apnea. Now, there are other abnormalities that we deal with that are congenital in nature. One of them is a diaphragmatic hernia. A diaphragmatic hernia is one of the components where the diaphragm herniates, and we can get issues with their intestinal organs moving into their chest cavity because of that. BVMs actually can make things even worse because as you squeeze that pressure in, it can actually distend the abdomen and then actually push more contents into the thoracic cavity. Last thing we want to do is have more intestines or organs into the chest cavity and less room for oxygenation or ventilation to occur. We have I can never say this, meningomenency. I'm not saying that properly, but this is the one where you're looking up here in the upper left-hand corner. Spinal cord or associated structures are exposed. The spinal cord begins to develop on the outside of the vertebral column. exposing in like a outpouching in the back of the patient, which is very susceptible to damage to the central nervous system. Another one that you can see where we have a number of abdominal contents that actually fill into the umbilical cord as well. Cohonial atresia is another one that you can see, which is the presence of a bony or membranous septum between the nasal cavity and the pharynx. It makes it almost impossible. It makes it impossible for them to be able to breathe through their nose. Again, because the nasal pharyngeal airway, or the nasal pharynx, pardon me, is actually going to be impeded because of that bony prominent. Cleft palate is where we have a failure to close the upper portion of the palate, or you can even have a specifics with a cleft lip. And then Perry-Robinson syndrome, which is characterized with a micro jaw. The jaw is very small and typically is very retracted if there's any jaw at all, or chin at all, pardon me. And then we also know that typically is associated with a cleft palate as well. So what do we do when we are dealing with a neonate? What is the assessments that we need to perform? What's critical to our time immediately after birth? Well, obviously, your assessment begins as the child is introduced, as the birth occurs. Normal respiration rates for a neonate are going to be anywhere between 40 to 60 breaths per minute, and we need to ventilate as necessary. Typically, if you're anything less than 30, you want to consider some type of ventilation. Heart rate is normal between 150 to 180 at birth. A pulse rate that's less than 100 is going to indicate distress, typically severe acidosis or hypoxia. In that case, we would want to be aggressive with our airway management or ventilation. We also know that we're going to evaluate skin color as well, as that's a good indicator of how well both the pulmonary and circulatory system are functioning. And then we use our APGAR scores like we would normally. A score at 1 minute, we're not looking for a perfect score at 1 minute, but we're looking for an adequate score, and then an improved score at 5 minutes. An APGAR score is going to help us distinguish between newborns who need only routine care and those that are going to need greater assistance. A score between 7 and 10 indicates an active, vigorous newborn. Nothing necessary for us to do but continue to monitor and observe. A score of 4 to 6 indicates a moderately distressed newborn and may require some initial treatment for primary apnea, things like ventilations and components of that nature. A score less than 4 typically is going to require some type of resuscitation, including ventilations, chest compressions, and even more advanced procedures, up to and including things like intubation. And again, these are performed at 1 and 5 minutes. Again, we've talked about the APGAR scale quite well. You know that there's a total of 2 points that are available, and the goal is that you would have a score of 7 or higher. Treatment. We've recognized when and how to assess for our patient what is considered normal respiration rate, ventilation, things of that nature, but we also need to make sure that we recognize how do we make improvements along the way. What are the interventions that we need to perform? We know that our treatment really begins prior to delivery, including things like preparing our equipment and assembling our equipment to make sure it's ready, and caring for mom. As we know, when we care for mom, we're in essence caring for the neonate. The vast majority of term newborns require no resuscitation beyond clearing of the airway, maybe some mild stimulation, and then keeping them warm to maintain body temperature. One of the things that you'll see here in this image is the inverted pediatric treatment triangle. This inverted triangle allows you to recognize what we do first before moving on to a more advanced component. One of the things you can see right off the bat is that basic techniques come first before we consider anything with advanced procedures. We know that drying, warming, positioning, suctioning, tactile stimulation is a great way to try to improve your patient initially. If they don't respond or respond sluggishly to that, we can administer blow-by oxygen. If we recognize that there's a need for ventilations, maybe a heart rate less than 100 beats per minute, we can go ahead and begin some bag valve mask ventilations. And if our heart rate falls below 60 beats per minute, we can go ahead and begin chest compressions. And again, that's at a different ratio. That's at a ratio of 3 compressions to 1 rescue breath. We'll talk more about that as we move on. That should take care of the majority of problems. We'll continue to assess regularly, every 30 seconds, to see if we have any improvement and if we can discontinue any of that basic care. If the patient continues to have noted problems with their skin color, their circulation, their responsiveness, we're going to go ahead and need to move into more advanced procedures. This is rare, but when it does occur, we need to make sure we're well prepared. One of the core things we recognize initially is again the need for oxygenation to reverse hypoxia, to reverse acidosis. Intubation is one of those primary components that we're going to do. Intubation in a neonate takes precedence over any type of peripheral vascular access or interosseous access for medication administration. That is the last thing that you will do. But we will intubate well before that. So what do we need to do? Well, establishing an airway is a critical step for the newborn. However, bulb suction during delivery and following delivery was once a very common practice. However, it has been found now to be relatively ineffective and actually can cause more harm than good, primarily in the form of stimulation of the vagus nerve, leading to neonatal bradycardia. The last thing we need to do is to have a child that's in distress that we decide to suction, that then becomes even more severely distressed because of the fact that they're now bradycardic. Suction the baby's mouth first and then the nose if it's needed. The reason why is that we know that stimulation of the nares actually stimulates the child to breathe into and potentially aspirate any fluids that are in their mouth. Remember, one hole versus two. Do the mouth before the nose. We know that there's a large amount of secretions that can be there, and if that's the case, we can go ahead and suction. It's preferred if we're going to suction that we use a Delaney trap. That's going to be what the image is located right here. The idea behind that is it gives us the ability to collect a specimen to be able to do that. Oftentimes those can be used by a suction device or even, believe it or not, by your mouth. I wouldn't do that in the field, but very similar these are to the nose Fritas, if you're familiar with that, where you suction out their mouth through their or your mouth through their nose. Meconium is another component. There's a prime example of what meconium staining looks like. It's a very dark colored type coating to the child. We do not perform orangeal or nasopharyngeal suctioning. You're just not going to be able to get all that meconium out that's in there. The best thing that you can do is to go ahead and to try to get out anything by wiping down the child, and then consider suctioning through the ET tube, or going ahead and intubating, push suction on and pull the suction out, and then dump the tube, put a new tube in, or at least intubating the child just to secure an airway. Yes, we know that meconium is fecal matter, and yes, we know that if it's in their lungs, it can lead to a massive infection, but we can do things at the hospital, at the NICU, to be able to offset those poor outcomes. One of the things with establishing an airway is, believe it or not, is stimulation is one of the most important techniques you can have. It will help you establish an airway more effectively than many of the other tools you would use on that of an adult. Drying and suctioning produce enough stimulation to initiate respirations in most newborns. Stimulation of the newborn requires flicking of the feet or rubbing the back in a circular type motion. I'm a bigger fan of flicking the feet, trying to get them to wake up that way, but rubbing the back or rubbing the chest is another way in which you can stimulate the child. We know when children are born that they are slimy, that they are wet and slippery. And when you are wet, you are going to lose a lot of heat because of that. So one of the things we need to do is we need to minimize any heat loss, because we know that threatens newborns. So keep them warm, keep them dry, have lots of linen when you prepare for delivery. Deliver the child, or dry them off, grab a clean new towel, and then continue to keep them wrapped and warm. Preferably allow for skin to skin with mom, and even encouraging things like breastfeeding can help improve child circulation as well. We want to make sure that we recognize that the core temperature can drop as quickly as 1 degree Celsius from its original temp because we fail to dry the child properly. So remember, warm, dry, stimulate. Here's how we prevent heat loss. We dry the newborn immediately. We maintain a room temperature that's 74 to 76 degrees. In the back of your ambulance, if you're transporting a newborn, you need to be uncomfortable with where the heat is set. It's not about your comfort. It's about making sure that that child is warm, and that becomes extremely important. It's so important that the state of Michigan made changes to the required equipment to keep heating pads on the ambulance. Unfortunately, they were having some issues with excessive heating when it was chemically reacting with oxygen, and so those are no longer on the trucks, but the concept remains the same, that keeping the child warm, maintaining temperature is extremely important. Close and all your windows and doors to keep out any outside air, and then swaddle the infant in a warm, dry receiving blanket or other type of suitable material. In colder areas, you can use bottles or rubber gloves that are filled with warm water, which will also help keep the child warm. Now, the umbilical cord is one of those things, if you had an opportunity to cut, you're going to find that it's a lot more rubbery and slippery than you would deal with any other type of umbilical or any type of other cutting of cord like you would have in a simulation. We know the umbilical cord is going to be cut after you have stabilized the patient's airway and minimized heat loss. It is important to recognize that we want the cord to stop pulsating, and that gives us time to focus on the patient's airway and breathing. Remember, don't clamp the cord if the cord is pulsating. Those last couple minutes of allowing the child to get that remaining blood from mom really can make a huge difference in the amount of total blood volume that neonate has to start out life with. We also know to keep the newborn level with mother to avoid any type of transfusion of blood, right? We don't want to have the baby that's going to be up too high and allow for blood from the neonate to travel back down into mud, or back down into mom, or for it to go the other direction. Remember, gravity works, and clamping the cord should prevent further shifting of blood, but we want to wait until that cord has had a chance to stop pulsating. We place the first clamp approximately 10 centimeters away, about 4 inches away. You clamp, and you can take another 2 inches or 5 centimeters and clamp after that, and then you can cut in between. The idea behind this is give yourself enough room that if you were to need to use that remainder of the umbilical cord between your second clamping, according to this picture, and your umbilicus, that you could cut that back down and use that as a lifeline to apply a umbilical catheter as an IV lifeline. And again, it's important to check that for bleeding regularly to make sure that there's not any blood loss around any of those types of clamps. If you lose clamps, you can use ties, you can use twisty ties. There's a number of things that come in the OB kit. But remember, it has to be effective, so we may have to go back and check it again. All right, guys, let's go ahead and switch ideas here to the distressed newborn. When we're dealing with a newborn that's distressed, there's a number of things that are going to be going through your mind. Again, we have to suppress the urge to have that normal sympathetic response, the flight response, the fight response, and we need to try to focus our minds to understand what is the underlying component that's leading to the distressed newborn. One of the areas that is relatively common in a distressed newborn is that of meconium staining. We know meconium is a particulate. It is fecal matter, and particular meconium is where it's very thick, pasty, or granular in nature. And then we also know that meconium staining can be more of a liquid component that's going to cover the child and just kind of discolor their skin. Regardless, any of that meconium is going to lead to the likelihood of that neonate, or fetus in that matter, being distressed during pregnancy, either during the delivery or complications immediately before, or at some point in time during the pregnancy. The biggest cause for concern we have is aspiration of meconium, because that can lead to significant respiratory problems. We know that most common problems experienced by newborns of life involve the airway, as far as newborns that are likely to have complications. Because we know that when we're dealing with the airway, we're talking about ventilations and oxygenation, and impeding either one of those in a pediatric patient or neonate leads to a major concern in their stability. They're more acidotic, they're more hypoxic, leading to the opening of those different ducts that are closing. All of those are concerns to us. We also are going to pay close attention to the circulatory system, because we know that ventilation is extremely important for the cardiovascular system to maintain its properties. Fetal heart rate is one of the most important indicators of neonatal distress. Hypoxia will lead to bradycardia. If the heart rate is less than 100, we need to provide oxygen to correct the underlying hypoxia. We also know that we need to make sure that we recognize that if the heart rate is slower than 100, we're beginning bag valve mask ventilations, and if it's less than 60, we know the circulatory system is not going to be able to compensate, so we need to provide external chest compressions for them. One of the things that's important for you to recognize is in your flip guide, your ECC flip guide, grab mine, there we go, page 74. '74 is going to take a look at, this is actually on the slide, but it's actually going to take a look at the neonatal resuscitation algorithm, because there's a lot of components that we're going to need to implement for this. I'm going to give you a quick overview for this, and I'll insert an image here, as you can see. One of the things that we start to recognize is that we know that we have birth that occurs. We're going to try to go ahead and make sure that the child is warm, dried, stimulated, and see how well we can improve them through external stimulation. From there, we're going to go ahead and take a look at apnea, gasping, and then we're going to take a look at their heart rate. Is it less than 100 beats per minute? If the answer is no, well, labored breathing, or is there persistent cyanosis? If the answer is yes, consider supplemental O2, some type of positive pressure ventilation, or even CPAP for that matter. If the answer is yes, that the heart rate is below 100 a minute, we're going to go ahead and provide positive pressure ventilation, or PPV. We're going to use our pulse oximetry, and we're also going to apply the cardiac monitor. If the heart rate, again, remains below 100, then we're going to go ahead and need to check chest movement, ventilation, to correct steps that are needed. Maybe that's going to be something as far as making sure that our endotracheal tube is placed properly if it's in there. We've got a good seal on our mask, all those things if they're needed. If the answer remains heart rate above 100, then we want to continue to have post-resuscitation care, looking primarily at maintaining the child at where they're at. Again, ensuring adequate ventilations, oxygenation, and circulation. If the heart rate falls below 60 beats per minute, we would want to intubate if not already done so. Go ahead and consider chest compressions, coordinate that with our positive pressure ventilation, utilize 100% of oxygen, ECG monitor, and then again continue to pay attention. If the heart rate remains below 100 or below 60 after chest compressions, then we're going to go ahead and begin to consider intubation if we haven't already done so, followed by our medications, which may include things like peripheral IV access or IO access and administration of epinephrine if the heart rate continuously remains below 60. And then we also want to consider things like hypovolemia or potential pneumothorax in those circumstances. The other component of the flip guide that's a really good one to take a look at here is as we looked at that initial assessment and stabilization of the inverted pediatric triangle, is again going to be on page 73. It looks again like this. The image will be here for you. But you can see it focuses on, again, basic before advanced as we get to go through there. You're going to see that the new guidelines from American Heart are going to contradict slightly what is in your textbook as far as the actual layout for care to be provided to that patient. Again, intubation actually comes a little bit earlier than actual chest compressions in the new AHA guidelines. So, as we go back to the resuscitation aspect of it, the vast majority of newborns do not require resuscitation beyond basic stimulating, warming them, maybe some ventilations if necessary. But beyond that, it's not much. We know that EMS units should carry a neonatal resuscitation kit, but most only carry what's required. It's not required by the state of Michigan for you to have a neonatal resuscitation kit. Services that hold that gold standards typically will, others do not. So you may have to do a lot of hunting for equipment that you need to use based on the size of that child. Most agencies do not maintain specific neonatal kits. It's either a cost issue or it's some type of use versus expiration date. But the importance of recognizing the need for the right equipment before you get into that circumstance is huge. So be prepared when you start your shift. Again, here's that inverted pyramid for resuscitation. I just want to point out one last time that in the new AHA guidelines, these components are switched around. I would still say for your national registry exam, these are the more common core basics. These are considered advanced. You would want to go ahead and continue to dry, warm, stimulate, and suction, provide oxygen, bag valve mask ventilations, chest compressions, but be aggressive when it comes to intubation in the prolonged resuscitation or the neonate that's not responding as quickly as you'd like them to. Step one is drying, warming, and positioning the child, suctioning, and then performing that tactile stimulation. Minimize heat loss, keep them dry, keep them warm by wrapping them in a blanket, and position the head lower than the body with slight neck extension. That's going to be helpful as far as establishing a nice, good open airway as well. And then suction if necessary, but no longer than 10 seconds. And remember, if meconium is present, we may have more complications associated with that respiratory issue. The newborn assessment parameters, we're going to look at respiratory rate, somewhere between 30 to 60 breaths per minute. If it's inadequate, do it for them. Remember that the normal rate that we're going to ventilate is going to be at 40 to 60 breaths per minute. If it's less than 30 breaths per minute, we need to be aggressive with our care. Again, especially if they're not responsive to tactile stimulation. Heart rate should be somewhere between a normal of 100 to 180 per minute. Heart rate greater than 100, I'm okay with it. Less than 100, I'm going to want to go ahead and consider positive pressure ventilation via bag valve mask for 30 seconds. Then I'll stop, then I'll reassess. If things are better, then I can discontinue some of that treatment. If not, I'll continue. The third component for assessment is color. We want good color. Normal color, pink, warm, and dry, is good. Peripheral cyanosis, not so great, but it's not so bad. If they're pink in the core and blue in their extremities, we can oftentimes stimulate them, provide some oxygen, life is good. If central cyanosis is present, again, move right to that bag valve mask and provide them with adequate ventilations. APGAR. We've talked about APGAR quite a bit. Remember, it happens at both 1 minute and at 5 minutes. If we're going to have to go ahead and do some type of blow-by oxygen, we're going to want to, or supplemental oxygen, we're going to want to do that most likely in the phase of being blow-by. Blow-by oxygen, you can take a mask and use a mask to blow-by. You can use supply tubing. I've used the non-rebreather mask and just cut off the portion of the nose of the mask to make it a little more of a fan-like display of oxygen. As you are about 1.5 inches away or so, you're going to be about 40% of your oxygen. And the goal is to recognize that we want oxygen to get into the child, but we don't want to have oxygen just blow across their face or their eyes. It can cause a number of issues in drying out of some of those tissues. In the short term, it's not really going to have any major impacts on our patient, and we know not to withhold oxygen. But just be conscious of how much oxygen you're flowing across that child's face, and if possible, maybe there's a mask that you can use for blow-by or supply tubing that will be a little bit more adequate. Another thing that your textbook will oftentimes talk about is if you can take a foam cup or a paper cup and then go ahead and pop a hole into it, slip your supply tubing into the bottom of it. The child can either hold on to that if they're old enough, or at least have mom hold on to the cup and direct that oxygen over their mouth and nose. I'm a fan of using a non-rebreather. Cut the nose off the adult non-rebreather. It makes a nice fan, and then you can have mom just kind of hold that in place and provide that blow-by oxygen. Step 3 is going to be ventilation. So heart rate in this case is less than 100 beats per minute. We've got some type of primary or secondary apnea, and we're definitely seeing issues including things like central cyanosis. In this case, we want to go ahead and ventilate at 40 to 60 breaths per minute, especially any child breathing less than 30 or a heart rate less than 100. And remember that we know that children oftentimes are going to have higher airway pressures, so your pop-off valve, which we normally would keep on there, so as we squeeze the bag, if it exceeds 10 centimeters of water, it pops off to relieve that bag pressure. We may need that in a neonate, so you may have to shut that off. Just like we may have to shut that off in a pediatric asthma attack because of the increase in resistance, same thing as we deal with a neonate. Intubation exists, but only for certain conditions. Here they are. The bag valve mask unit does not work properly. The tracheal suctioning is required, right? For example, like thick meconium, where you're just not able to get in adequate air because of the secretions or buildup inside the airways. We know that prolonged ventilation isn't going to be necessary, so maybe we're dealing with some type of congenital abnormality or other long-term problem. We have a diaphragmatic hernia because we know ventilation with the BVM can oftentimes make that more challenging unless we have that direct tube placed into the trachea to isolate the lungs. And then inadequate respiratory effort is found. They're not improving the bag valve mask ventilations we need to secure a more permanent airway. All those will be important for resuscitation in regards to using an endotracheal tube. Chest compressions, if you take a look at your field guide again on page 75, you're going to see that there's more information about chest compressions. So if the heart rate is less than 60 beats per minute, we're going to go ahead and initiate that chest compression. if the heart rate is going to be less than 100, we're going to do our BVM. So remember, BVM less than 100, compressions less than 60. We're going to again compress on the chest. Remember that we're going to compress in the lower third or lower half of the sternum, and we're going to do so at a rate of 100 to 120. The compression to ventilation is going to be at a 3-to-1 ratio, 3 chest compressions for a pause for ventilations. People often say, well, why is that? Well, so far we really have outlined the importance of preventing or reversing hypoxia or acidosis. We know that neonates are very dependent on oxygenation in order for their circulatory system to close. We know that there's a need for the pressure changes, and the lungs need to be working properly. So ventilating is extremely important here. So your resuscitation efforts now become a 3-to-1 ratio rather than what you would typically see of 30-to-2 or 15-to-2 with 2 rescuers. 3-to-1 remains even if there are more than 1 rescuer. Typically, in this case, there are. From there, every 30 seconds, I'm going to reassess heart rate, respiration, skin color, and see if there's any improvements. If not, I can continue. I may have to get more aggressive, working down to the base of my pyramid to consider medications if I've had multiple rounds of compressions and ventilations without any improvement into the patient. Here you can see your chest compressions. For very small newborns, encircle the chest with your fingers so they overlap your thumbs and the sternum, and they should be just below the imaginary line of the nipples. That will be in the lower half or lower third of the breastbone. We also know for an oversized newborn, you may actually have to place your fingers side by side so you can be able to do better compressions as such. And then for anyone where they're too large for your hands to encircle the chest, you can use your 2 fingers, however you so choose, to go ahead and do those compressions, maintaining that adequate chest recoil and compression rate. Now there are some intubation considerations that we have. We know that we always use an uncuffed endotracheal tube. Well, that's not necessarily true anymore. The reason why it's preferred for us to use a uncuffed tube is that we know that neonates or pediatrics have a much more narrow and funnel-shaped airway. Because of that, it's nice and easy for us to get a nice tight seal with an appropriately sized tube that does not have a cuff. However, in the pre-hospital setting, paramedics oftentimes will undersize a tube because of concern that the tube won't be able to fit, or there may be complications with inserting the tube. That's where you're going to see a change in your MyMedic cards, for example, in regards to pediatric equipment. It's going to call for mostly cuffed endotracheal tubes. And so that's okay for us to use. We do need to be concerned that when we use a cuffed endotracheal tube in a ped, that we do not overinflate that balloon. By doing so, it can actually blanch the capillaries, move out the tissue, the blood in the tissue, and can lead to tissue necrosis if they're prolonged intubation for any long period of time. We also know that intubation bypasses the glottic functioning and eliminates the natural PEEP that occurs. So PEEP is important in order for the alveoli to stay inflated. It's important for adequate gas exchange or for pushing out of fluids that are necessary. So when we are using endotracheal intubation with the neonate, we want to provide that PEEP of 2 to 4 centimeters of water when ventilating. You would need to add a PEEP valve to your BVM in order for that to occur. Some BVMs come with it on there, most of them require an attachment. We do know that with intubation, gastric distension can occur, especially when we're prior to intubation, when we're using aggressive bag valve mask techniques. As the abdominal contents or the stomach inflates, it's going to push back on the diaphragm, and it's going to interfere with the ability for that child to have adequate lung expansion. Again, if we can't get air into the lungs, we can't get oxygenation, we get hypoxia and acidosis, and we end up getting a very distressed newborn. Again, remember that if you can, and your scope of practice allows for it, consider placing an oral and nasogastric tube. That'll help decompress the stomach and ensure that oxygenation is at its maximum, because we can get full tidal volume because of the reduction in air inside the stomach. Last but not least is oxygenate and intubate first. It prevents misplacement of the gastric tubes into the trachea. So if you can, oxygenate, intubate first before you consider placing a gastric tube in. The last thing you want to do is place that gastric tube actually down into the lungs. Our final step in the resuscitation inverted triangle is medications and fluids. Vascular access can be most readily managed by using the umbilical vein. We know that the umbilical vein is going to have two arteries and one vein. The vein is larger and thinner walled. When you actually take a look at it, what you would do is you would grab the umbilical cord, you would cut it down to about an inch or so that's left, enough for you to be able to secure your catheter. And then you would go ahead and squeeze that opening, and by squeezing it, you're going to actually create the image that's next to it, in essence, which is going to be the smiley face, where you'll see two small circles and a larger circle, which oftentimes when squeezed will actually look like a mouth. That larger, less pliable, probably more pliable, more flexible vessel is the umbilical artery. And that is going to be where we're actually going to go ahead and umbilical vein. And it's going to be where we're going to slide that down through. That umbilical vein is going to provide access directly into the arterial system for that child. It is preferred that when you look at doing these types of IV access through an umbilical cord, that you would use an umbilical catheter. An umbilical catheter is about 18 inches long or so. They come in different sizes just depending on the child. But in essence, the large catheter that you would slide all the way through until it basically hits where the liver is. And at that point, you would back it up slightly and secure it. Most services in the area don't carry those, but you do carry plenty of angiocats. You will take yourself an IV needle, remove the catheter using Sale technique, and then take that catheter and insert it into the umbilical vein. At that point, you can secure it with a clamp or some type of tie or twist tie, all of which is going to prevent backflow of blood. It's probably even more prevalent now to say that you can also use an IO with the automatic IO devices, the drill guns that we have. All those allow for easily attainable peripheral IV access as well. That are probably going to be more even secure than using just a typical IV catheter. Other routes, again, endotracheal, you can get a peripheral vein. That could be in the scalp, that could be anywhere on the body for that matter, and then also interosseous. And then remember that fluid therapy should consist of 10 to 20 mLs per kilogram for a neonate. For a typical pediatric patient, beyond the 1 month of age, we're going to probably do 20 mLs per kilogram. But for neonates, from birth to 1 month, we're going to do them in 10 ml per kilogram boluses with the ability to repeat as necessary. The umbilical cord, here's another example of what that looks like. You can easily see here's that umbilical vein, here's those two umbilical arteries. It's going to be traveling down through, so as you were to squeeze these in, you could easily pass the catheter down through and then secure the catheter in place with tape or a tie or a clamp of some type. There's a lot of different medications that you can see utilized. Primarily they include things like epinephrine, antiarrhythmics, Narcan, sodium bicarb, pressor agents, things of that nature. Components that we've been talking about throughout the program. Again, it is important to reference that pediatric medications are always weight-based drugs. We don't give a kid a medication based off a pre-filled ampule. Not that we should even do that for an adult, but we need to make sure that we have the right amount of medication for that specific patient based on their specific weight, or a measurement of their weight using things like the mimetic tape or the Braslo tape in conjunction with your mimetic cards. There are some complications that can happen to a delivery of a normal child based on complications from mom. One of those is maternal narcotic use. These delivery complications have been shown to produce low birth weights. They increase the risk of birth deficits, and such infants may demonstrate actual withdrawal of symptoms after birth because they were dependent on that narcotic supply from mom. Things that you can see include tremors, startles where the kid kind of jerks and moves like that nature, decreased alertness, and then obviously respiratory distress. It's going to be one of those things when you recognize this happening, and it will happen probably in your career, you're going to be screaming for where is that resuscitation kit. We used to use Narcan hardcore on this, right? The reversal to a child who's been exposed to narcotics from mom is to get them out of their system. Let's use Narcan. The problem is that actually can facilitate a withdrawal, where the child can actually begin to have withdrawal symptoms because they've been exposed to that regular use of narcotics throughout their development and throughout the pregnancy. The last thing we want to do is to throw that neonate into seizures or into a withdrawal state or into some type of unstable event, which otherwise could have been prevented. Now we're going to support their airways. We're going to go ahead and monitor them aggressively. We can consider Narcan, but it's going to be in very small doses, and it's only under the direct observation or directive of a medical control. With neonate transport, we know that distressed neonates are going to have to be transported at some point. The safest way to transport them is through an isolette, something where they can be transported on their side, something that can be transported where they're going to maintain warmth, maintain oxygenation, all of those things. We know that in the back of an ambulance, we have a very difficult time regulating temperature. We have a very difficult time regulating the environment as a whole. And we know there's a lot of moving parts that have to go along with that. So containing all of that into one isolate cart is one of the best things that you can do. And so we see things like the baby bus or a NICU bus that's going to allow for the child to be stabilized at one facility and then maintained at that level of care until they received at the neonatal intensive care unit. There are some specific neonatal situations that the paramedic must be aware of. Let's go ahead and get into those. Some of these include things like meconium-stained amniotic fluid, which we've talked about, apnea, both primary and secondary, diaphragmatic hernias, bradycardia, prematurity, and respiratory distress. These also include things like hypovolemia, seizures, fever, hyperthermia, hypoglycemia, vomiting, and diarrhea. Let's dive a little bit deeper into some of those. With meconium-stained amniotic fluid, we know it occurs generally about 10 to 15% of deliveries. Not very often, but more often than other components. Fetal distress and hypoxia are the number one concerns, as the amniotic fluid is going to be most likely inhaled and fill the lungs. That thick meconium is aspirated in the lungs in utero while they're or within the first few moments of birth. And again, that can produce a significant amount of respiratory distress. We may also see things like partial obstruction of some airways that can even lead to a backup in pressure, which can cause a pneumothorax. Intubation and suctioning may be necessary. Again, we have to be careful with that. If we are going to suction, we'd place the endotracheal tube in place and then go ahead and suction on the withdrawal of that tube. And we're going to do that with a meconium aspirator, which allows for the suction tubing to hook to your endotracheal tube. And then we're going to suction at no more than 100 centimeters of water or less. And again, repeat as necessary for that patient. Most of the time, recent studies have shown that the need for aggressive intubation and suctioning, it doesn't help. It actually leads to more increased likelihood for hypoxia. So choose wisely when you need to do this or not. Are you able to maintain your patient with supplemental oxygen and bag mask ventilations? If that's the case, we may want to consider holding off on additional intubation and suctioning techniques specifically for meconium. When in doubt, intubate your patients if it's necessary, though. Apnea, we again talked about this as the primary cause of either hypoxia or hypothermia, but there's more to it than just that. It could be narcotic or other central nervous system depressants. We could have weakness of respiratory muscles, septicemia or sepsis, metabolic disorders, or central nervous system disorders. Most of the apnea that we're going to be dealing with really focuses on stimulation, tactile stimulation, ventilations if necessary, and then intubate if we're recognizing this is becoming a prolonged period of apnea. Diaphragmatic hernia, again, very rare condition, only 1 in 2,200 births. Survival rate is 50% in those that's requiring ventilatory assistance in the first 18 to 24 hours. It's nearly 100% fatal if it's nearly 100% survival rate if ventilation is not needed. Assessments are your assessment findings are probably one of the most important things you can tap into. We know that you're going to see little to severe distress present from birth. You may see dyspnea and cyanosis that's unresolved after you've applied ventilations or even intubations. You may see a small, flat abdomen or a sucking in of the abdomen because their abdominal organs are actually in their chest. And then bowel sounds are obviously, as you listen to lung sounds, you're going to hear bowel sounds. And when you go to listen to bowel sounds, you're not going to hear much of anything. Heart sounds are also going to be displaced. We know that we're going to see a medial sinus shift, where the heart is actually going to move to the right, because the left lower portion of the diaphragm is the weakest port, as we start to see things like, for example, the great vessels or your esophagus travel through. Pardon me, esophagus, but bowels travel through. Again, it's most commonly going to occur on the left side, and it is a postlateral segments of the diaphragm that are going to be torn. Here's an example of what that looks like. You can see immediately here we have our diaphragm, which should be coming up like so. It's now burst, and so now we're getting the stomach and some of the intestines that are actually going to be placed up into the thoracic cavity, moving the heart to the right, because again, the left side here is going to be the weakest, and then we're going to have displacement of that lung tissue and compression of our great vessels, all of which is going to really be a bad outcome for that child if not corrected immediately. Management includes position. We want to elevate the head, so we want to make the head elevated in comparison to their legs. And then we also do not want to use a bag valve mask. It can inflate the abdominal organs. We can get gastric distension. If we need to be aggressive with our airway, we want to intubate early and provide ventilations through that route directly. Bag valve mask ventilations is going to allow for air to get into the lungs and into the GI system, which we do not want to have. It's just going to complicate things and make them worse. Bradycardia. Bradycardia is caused most commonly by hypoxia. We talked about that: hypoxia, acidosis, and hypothermia. The following procedures of we need to follow the procedures of the inverted pyramid. We need to make sure that we resist the temptation to treat bradycardia in newborns with pharmacological measures. We cannot. Epi is a drug of choice if we get down to that point, but remember, we have a lot of components of our BLS triangle that we need to initiate with. Those include drying, warming, positioning, suctioning, tactile stimulation, moving to oxygen, either blow-by or bag valve mask ventilations if our heart rate is less than 100, and then chest compressions if our heart rate is less than 60. And again, that's at a 3-to-1 ratio, 3 compressions, 1 rescue breath. From there, if that doesn't work, we'll continue to be aggressive treating the hypoxia by moving with intubations early, and that we also are going to go ahead and consider medications. If that's the case, epinephrine is the drug of choice if they're unresponsive to the above measures. We also know that prematurity can happen. An infant that's born prior to 37 weeks or has a weight range of 0.6 to 2.22 kilograms, or about 1 pound 5 ounces to 4 pounds 13 ounces, they're at a greater risk of complications. We know they're at a greater risk of complications because the respiratory system is less developed. The head or the brain can lead to injuries with delivery, causing components of hypoxia and changes in blood pressure. We can also see intraventricular hemorrhage and fluctuations in serum osmolarity, and then hypothermia. There's just so many complications that can arise when a child is not fully developed, yet arrives early. It's also important to know that one of the last things that happen is that you are going to go ahead and have a major concern about lung development. We need to make sure that those lungs are developed. Believe it or not, fun fact, lung development actually is more pronounced in females at birth than males, especially when they're premature. So as females, you are superior right from birth. We also know that prematurity should not be a factor in short-term treatments. You shouldn't treat your patient any differently. You are going to need more specific equipment based on the size of the neonate, but most importantly, maintain the airway, maintain oxygen and ventilation, and maintain temperature. Those things will help you regardless. Respiratory distress and cyanosis occurs most frequently in premature infants. They have an immature central respiratory control center. They're easily affected by their environmental or metabolic changes that they have, and they'll present with things like tachypnea, paradoxical breathing or seesaw type breathing, intercostal retractions, nasal flaring, and a respiratory grunt, like as they're trying to breathe. We've got to be on top of our game when it comes to a respiratory distress or cyanosis, because being aggressive is important early because it can resolve the problem. If not, we may have to move on to more advanced procedures with a resuscitation. Again, we're going to follow that inverted pyramid of treatment, paying a close attention to airway and ventilation, chest compressions as indicated, And then we may want to consider some type of medications if necessary, especially if it's prolonged. Things like sodium bicarb to help any type of acidosis. Again, we need to make sure that that's appropriate dose titrated based on patient size. And then dextrose if the patient is dealing with hypoglycemia. Preferably, we're going to use D10. We now carry D10, or you can actually make D10 or at least D12.5 from a dextrose 50% solution. And then remember, keep the kids warm. Those are the basic things that we're doing for almost all children. Hypovolemia, we're dealing with blood loss. It is a leading cause of shock in newborns. We know that signs of hypovolemia include things like pale skin color, cool skin, diminished peripheral pulses, delayed capillary refill, even though there's normal ambient temperatures. When things are colder, you typically see a delayed cap refill in children. Not always the most reliable, but if they're warm, it should be a good tool to use. Mental status change is another, and then diminished urination or diminished of output of fluid because of a lack of core volume. Management includes the administration of a fluid bolus and assessing the infant's response. Again, as we talked about before, we're going to start that off at a 10 milliliter per kilogram bolus of an isotonic crystalloid solution, typically normal saline, 0.9% or lactated ringer. If that one bolus is not enough, remember you may have to repeat that up to 4 to 6 times, up to a total of 40 to 60 milliliters per kilogram of fluid. We do not use solutions containing dextrose, though, because again, it can lead to more problems with pre-existing hyperkalemia, or it can even make ischemic brain injuries worse. Seizures are something else that you might see. Typically indicates another underlying abnormality, like a brain neurological dysfunction, narcotic use, or withdrawal type symptoms, a number of things. There are a lot of different types of neonatal seizures, from subtle, tonic, focal clonic, multifocal, or myoclonic, all of which are concerning, but seizure activity can happen to any number of children. When we look at these common causes, mostly you're going to see things in regards to infection, sepsis, or fever, issues with hypoglycemia or hypoxic ischemia, encephalopathy with the brain, metabolic disturbances, meningitis, development abnormalities, or even drug withdrawal. Management is relatively simple. Provide an airway, maintain ventilation, and then administer some type of anticonvulsant, preferably something like benzodiazepines, like lorazepam or Ativan, or something like midazolam or Versed. We also know that seizure activity causes a lot of muscles to be used, which burns up a lot of sugar in children. So anyone that has a seizure should always get their blood sugar checked, but especially in neonates, we need to be concerned of hypoglycemia. So they may have to go ahead and administer some type of 10% dextrose solution if they become hypoglycemic. Fever. A fever is defined as anything greater than 100.4 degrees Fahrenheit or higher. It may be caused by a life-threatening condition like pneumonia, sepsis, or other major concerns like meningitis. But a fever is only a sign of other underlying issues. So we need to be we need to look out and seek out more information to gather details about what might be going on, especially in the case of meningitis. Assessment findings, we're typically going to see things like mental status changes, especially not necessarily as far as being altered, but they're definitely going to be irritated or having a hard time consoling, or maybe they're on the other end of the extreme where they're very extremely sleepy or hard to arouse. We typically see them have decrease in feedings, which leads to issues with dehydration because neonates primarily their source of food is liquid, either breast milk or formula. We also know that the skin is going to be warm to the touch, and we may see petechiae, which is going to be rashes that are localized in the chest or any area that's relatively warm. You typically will see that type of petechiae. Management, again, airway ventilation is extremely important. We do not want to aggressively cool the child. Rapid rise in fever can cause massive discharge of energy within the brain, leading to seizures. So can a rapid drop in temperature. So don't use things like cold pack. You can go ahead and expose the child, take them down to nothing at all, get them down to naked, and allow for them to cool naturally. We again consider chest compressions if the patient is bradycardic, or if they are hypoxic and a respiratory rate is less than 100, we can consider the use of back valve mask ventilations. It's also important that we consider the use of some type of antipyretic agent, preferably your ibuprofen, Motrin, or your Tylenol. And again, most commonly, you'll see that utilized by family or by the parents, but not always. And so it's important to try to get that temperature under control without having it rapidly rise. Hypothermia. So let's talk the other end of the spectrum. Hypothermia presents as a common and life-threatening condition for all newborns. Again, especially after birth, they're wet, they're sticky, they're slippery, they're cold if we don't keep them dried, stimulated, and warmed. It also leads to the increased metabolic demands that can produce a variety of related conditions. Acidosis, pulmonary hypertension, hypoxemia, you name it. All those can become compounded because of hypothermia. The way that it will present, you're going to find the patient will be pale in color. Their skin will be cool to the touch, particularly in the extremities. We may see acrocyanosis, where we're dealing with cyanosis around the lips and areas of that nature, respiratory distress, possible apnea, bradycardia, central cyanosis, irritability initially, and then they become more and more lethargic as they continue to get colder and colder. So we have to be aggressive when it comes to managing that. Here's an example of what we would see where they have that acrocyanosis, or their pink is core, but their extremities are blue, and that typically has to do with the lack of circulation because of temperature. Management-wise, ensure adequate ventilations and oxygenation, again, like we've discussed, compressions only if necessary, and warm them passively. You can also consider them to have warmed IV fluids as well if they're significantly hypothermic. And then again, consider the use of dextrose, because dextrose, as it utilizes with the cells, helps metabolism, helps maintain and generate body heat. More common in those that are premature or small gestational age infants, right? The smaller they are, the more concerning we have when it comes to hypoglycemia. Typically, if we have twins, the smaller of the two is going to be the one that we're more concerned about with hypoglycemia, or if the newborn is from a diabetic mother. Infants with hypoglycemia may be completely asymptomatic. So if you get a kid that's early or in distress, check a sugar. We're going to not poke their finger, we're going to actually poke their heel and use it with our glucometer that way. And if a blood glucose screening is less than 45 milligrams per deciliter, then we're going to treat it. Remember, that's different than an adult. An adult is less than 60, we begin treatment. And a neonate, less than 45, we're going to go ahead and consider the use of D10 or D12.5. Your assessment findings for hypoglycemia, you may just have minor twitching, you may have full-blown seizures. It can be anywhere on that spectrum. They can be limp, they can be lethargic, they could have eye rolling or high-pitched cry, they could have apnea, irregular respirations, or even cyanosis. It kind of plays the gamut that way. So when in doubt, check a sugar. Less than 45, administer dextrose. Management, again, we talked about this, is managing the airway and ventilations, compression as necessary, and then administer dextrose, preferably D10, or we can go ahead and do D25 or D even 12.5 for that matter if we need to make it ourselves. Most area agencies are now carrying D10 because we know it's a much safer way of giving dextrose, especially to a neonate. And then remember, folks, maintain a warm child. Maintain that warmth. With vomiting, vomiting is not common. There's a big difference in what we think of vomiting and what is spit up, right? Spit up is you get a big belly full of stuff and they burp and spit out a bunch of whatever they've recently consumed, formula or breast milk. Vomiting, on the other hand, is a much bigger problem. Don't let this get confused with regurgitation or burping. Vomiting is where we're having some type of projectile release of vomitus from the child. That is a sign of a severe medical issue. Assessment findings will find where there's a distended stomach, signs of infection, increased intracranial pressure, or even drug withdrawal. You got to have a little bit more background information to recognize it's not normal for a child to throw up, especially a neonate, I should say. Management, airway, 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 ventilation, ventilation, ventilation. And we know that with regurgitation or vomiting, we're going to see an increase in vagal stimulation because of the vomiting reflex, and that's going to lead to issues with bradycardia. Remember, bradycardia leads to more and more severe hypoxia, leads to a death of the child. Diarrhea. Diarrhea can be pretty severe in kids. These guys don't have a reserve capacity of fluid. They don't have a reserve capacity for dextrose, and so it can lead to a lot of major concerns with electrolyte imbalances. Normal for a child is 5 to 6 stools per day, along with having wet diapers. That's quite a few diapers you can go through in one day. When they have diarrhea, eventually those things are going to go ahead and begin to increase more, or eventually they're going to just stop altogether because they're no longer producing enough fluid or have enough fluid on board to create a liquid form of diarrhea. There are so many different causes for this. They include things like bacterial or viral infections, gastroenteritis, lactose intolerance, phototherapy. This is where they may have to use Billy lights to treat any type of jaundice, or they'll even just place the kid underneath in the sun in order to kind of help get rid of some of that jaundice. Neonatal abstinence syndrome, or NAS, thyroid toxosis, and cystic fibrosis. Your assessment findings, you're going to be looking for things like loose stool, decreased urinary output, and other signs of dehydration like prolonged cap refill, cool extremities, and listlessness or very lethargic like patients. Most of the management is relatively simple. Again, airway and ventilation are of the most important, ensuring adequate oxygenation, and then chest compressions as necessary for the neonate. Again, consider fluid administration as we talked about. There are some common birth injuries that we can deal with as well. These happen about 2 to 7 out of every 1,000 live births. They occur due to movement and pressure throughout the actual birth canal. These can lead to 2 to 3% of fetal death, causing issues like cranial injuries, spinal injuries, fractures of the clavicles or other areas for that matter, and then organ or nerve damage, including liver, spleen, kidneys, or that diaphragmatic rupture that we talked about. Again, there are a lot of risk factors that are associated, including things like prematurity or post-maturity, prolonged labor, abnormal presentations, an explosive delivery, shoulder dystocia, or a diabetic mother. Most of the assessment findings for these patients are really going to be focused around identifying what is the major injury that has occurred. Do we have things like diffuse or sometimes ecchymotic or edema swelling of the soft tissue around the scalp? Have we noticed any type of paralysis below the level of the spinal cord injury? Or is it paralysis of upper arms with or without paralysis of the forearm? And then is there any type of diaphragm paralysis as well? All of which can lead to a major distressed newborn. We also want to make sure we pay attention for movements on only one side of the face when they're crying. They should have equal grimace. We may also see things like inability for them to move their arm freely on the side of a fractured clavicle, and then lack of spontaneous movement in an affected extremity. Hypoxia and shock are also very common signs with any type of damage during birth. Management for common birth injuries primarily has to do with, again, protecting the airway, making sure we have provision of adequate ventilation and oxygenation, and when needed, perform chest compressions as part of your resuscitation pyramid. We also know that newborns with birth injuries usually require treatment at specialized facilities, so make sure you're transporting to an appropriate NICU or MICU. For cardiac resuscitation, post-resuscitation, and stabilization, we know that the incidence of neonatal cardiac arrest is related primarily to hypoxia. Hypoxic patients begin to have acidosis, which leads to bradycardia, which leads to circulatory system collapse, organ death, and then death of the fetus or the neonate. Risk factors include bradycardia, intrauterine asphyxia, that could be clamping or closing off of the umbilical cord internally, prematurity, maternal drug use, congenital diseases, and intrapartum hypoxia. Remember, if you have no airway, you have no patient. In pediatric patients, the number one cause of cardiac arrest is hypoxia or airway-related issues. Your assessment findings are primarily going to be focusing around peripheral cyanosis, inadequate respiratory effort, and ineffective or even absent heart rate. We know that the management really needs to follow that inverted pyramid for resuscitation and administering drugs or fluids according to medical direction. Remembering that the fluid bolus for a neonate is at 10 mL per kilogram and can be increased up to 40 to 60 milliliters per kilogram. We also want to make sure that we're administering drugs according to that of that inverted pyramid as well. We start with basic before moving into more advanced procedures. We also know that maintaining body temperature and preventing hypothermia is critical when it comes to the success of resuscitation and stabilization of any type of cardiac-related issue. In summary, we've talked about the general pathophysiology, the assessment, and the management of the neonate. We spent a lot of time talking about the distressed neonate and what that looks like, from heart rate, less than 100, providing bag valve masks, to ventilations, to intubation when extremely necessary, and things like meconium staining. We talked about the chest compression ratio of 3 to 1 for a neonate resuscitation, knowing they need a higher volume of oxygen. And then things like for specific situations in regards to diaphragmatic hernias, not using a bag valve mask, but rather intubating your patient to provide ventilations. What to do with dehydration and fluid resuscitation, or even withdraw from maternal narcotic use. So hope this lesson has provided you with a good overview of what you're going to be dealing with in neonate. We'll continue to practice these skills throughout our simulation and lab experiences. Well, let's catch you on the next lesson.